We'll now listen to the third keynote lecture about bronchial thermoplasty for severe asthma, which will be delivered by Dr. Jamalul Azizi bin Abdul Rahman, MBB CHPAO, LRCP, LRCS. Dr. Azizi is a senior consultant pulmonologist at the Serdang Hospital, Selangor, Malaysia. For all participants, we instruct you to prepare your smartphone because Dr. Azizi will prepare one slide to scan the QR code. To Dr. Azizi, the floor is yours.
Thank you. Can you hear me?
Yes, doctor, I can hear you.
Thank you very much to the Mr. Chairman for the kind introduction. And I would like to thank the organizing committee of the 9th Jakarta International Chest and Critical Care Internal Medicine for inviting me to give this talk. So my talk is bronchial thermoplasty for severe asthma. I have no conflict of interest and I will not be discussing off-label uses. So these are some of the objectives of my talk. To evaluate recent advances in bronchial thermoplasty for severe asthma, looking at the emerging data from clinical trial and registries, patient selection, and if I have some more time, then I will go into the procedural aspects, number of activations, and the type of scope. So let's start with a difficult asthma case. I saw this patient 8 years ago. She was 27 years old then, female. She has asthma since the age of 14, and she is from Penang. I think most of you from Indonesia know where Penang is. And basically, she is a case of very severe asthma, frequent admissions and ER visit. She had at least 4 intubations in the past, and she was already on maximum medical therapy, and somebody put her on oral steroid, and she became pushing oil. And then she was then referred to me for further management. So is everyone ready with their smartphone now? Sorry, okay. This is the question in Slido. So you know the story there, a 27-year-old female, with very severe asthma. So the question is, after addressing comorbidities, triggers, and inhaler technique, what is the next step in the management of this patient? So can you scan the QR code there and click your response? Would you start her on omalizumab? Will you start her on dupilumab? Will you give macrolides? You would you would only offer bronchial thermoplasty if the lung function is more than 50% of predicted. So let's see the response now. Right. Do not be swayed by my talk just because I'm talking about bronchial thermoplasty. It doesn't mean that I'll be offering bronchial thermoplasty in this patient. So let's see the response. 44% of you chose bronchial thermoplasty only. All right, so the results keep changing now. Wow, 50-50 now. So almost 40% of you would choose bronchial thermoplasty now. Some of you are a bit more concerned, maybe would offer bronchial thermoplasty only if lung function, the FEV1 is more than 50%. Some of you would start biologics, omalizumab, and some of you would prescribe macrolide, 500 milligram TDS per week. So yeah, so the most popular response here seems to be bronchial thermoplasty. So let's see. So that's very interesting. let's see what I did to this patient. Right. So what is the definition of severe asthma or difficult to treat or difficult to control asthma? So it refers to a clinical situation where asthma-like symptoms and asthma attacks persist despite prescription of high-dose asthma therapy. And the treatment options for severe asthma are either monoclonal antibodies or bronchial thermoplasty. So, and for the sake of this talk, I will be focusing on bronchial thermoplasty. Okay, so what is the basis for um, bronchial thermoplasty? Well, and in BT basic in bronchial thermoplasty, we basically target the airway smooth muscle. So what is the basis behind this? Well, in the mid 70s, somebody suggest made the suggestion that if we could treat the airway smooth muscle, maybe we could control severe asthma. But beside the mechanical effect of the airway smooth muscle, the airway smooth muscle is also felt to play a role in hyperresponsiveness, inflammation, remodeling, interaction with epithelium and nerve, leading to uncontrolled asthma. And if you look at these models here, the airway remodeling, what happened in someone with severe asthma, basically you can appreciate excuse me, um, the airway smooth muscle hyperplasia or hypertrophy on the right side here, as opposed to the normal airway smooth muscle on the left-hand side there. And so what is bronchithermoplasty? Basically, it is a novel non-pharmacological therapy, the only one in its class. It involved the application of radio frequency energy to the airways or thermal energy, and basically it reduces the airway smooth muscle mass. So it is basically a debulking procedure. And based on one pivotal study, this technique was FDA approved more than 10 years ago for treatment of severe persistent asthma that is inadequately controlled despite treatment with ICS and LABA. So I think at this stage, many of you are familiar with the BT system. Basically, you have a unit here which generates the thermal energy. And then we have this catheter or LA catheter, which is inserted into the working channel of a standard flexible bronchoscope. And as you can see here, when the proximal end is actuated by the operator's assistant, the distal end will, the electrode array will expand, all right, and will come in contact with the surface of the airway mucosa. And then the operator, by pressing the foot pedal, you will generate the energy from the base unit here into the catheter, which will be delivered into the surface of the bronchial airway mucosa, the airway muscle underneath. So, what is the evidence that bronchial thermoplasty works? Well, in canine model, as you can see here, the left airway was treated with bronchial thermoplasty, and the right airway was not treated with bronchial thermoplasty. So what happened when we give methacholine into the airway? We apply methacholine into the airway, as we know that methacholine is an agent that can induce bronchospasm. And as you can see here, on the right side, the airway that was not treated with bronchial thermoplasty developed bronchospasm, whereas the left side, the left airway, which was treated with bronchial thermoplasty, remained patent. So anyway, when the first question that comes to your mind when you are faced with a case of um, uncontrolled or difficult asthma is actually, is this, are we dealing with asthma? So obviously, because obviously it is important to be sure that we are dealing with asthma, because we don't want to offer this procedure in somebody with emphysema or chronic bronchitis or bronchiectasis and so on. So we have to be sure that we are dealing with asthma. And then before you refer a patient for bronchial thermoplasty or BT, you have to make sure that you have already addressed all the following issues, such as comorbid conditions, um, therapy, therapy-induced comorbidities, asthma education, self-management, the technique, whether the controller medications and the amounts are appropriate for the level of control, compliance to management plan, environmental and occupational triggers. So all these issues have to be addressed, and before you refer the patient for bronchial thermoplasty. So what's the evidence? The early studies came from experimentation in dogs, as you can see here. You see that on the left side, untreated control in dogs, and another group of dogs which were treated with bronchothermoplasty. As you can see here, that group of dogs that receive bronchothermoplasty, there is loss of the airway smooth muscle mass. There's a reduction in the airway smooth muscle mass. And that study led to 3 human trials. You see on the left side here, COX-1, air and result trial, 3 human trials. All of them showed improvement in aspect of asthma management, such as symptom-free days, mild exacerbation, number of rescue inhalers. But all the 3 trials shared one thing in common. That is, there were a higher percentage of asthma-related adverse events in the group that received bronchial thermoplasty. And these 3 human trials led to the next trial, the AIR2 trial, which led to the FDA approval. So AIR2 trials was a 12-month study, a randomized study. There was one group treated with BT, and there was a sham group, meaning in the sham group, the patients received the procedure, bronchoplasty, but the thermal energy was not delivered to the airways. And they included adults with asthma, requiring high dose ICS and LABA, even included those with allergy asthma, those with lung function, at least more than 60% of predicted. They had to be stable, and they excluded life-threatening asthma and those with history of 3 or more hospitalization for asthma in the previous years. And look at the findings from the AIR2 trial. The primary endpoint was the AQLQ, Asthma Quality of Life Questionnaire. And you can see here, almost 80% of the BT group achieved significant changes in AQLQ, defined as more than 0.5. But surprisingly, there was a high percentage of patients in the sham subject. 64% of them in the sham subject also achieved improvement in AQLQ of more than 0.5. And there was also a reduction in days lost from work and school by 66%. And then in the secondary endpoint, they found that the BT group had fewer severe exacerbation by 32%, and reduction in emergency room visit by 84%. However, 6% or more of the BT subjects were hospitalized in the treatment period. up to 6 weeks after BT. And then the air-to trial was extended for another 5 years because people were not happy, because the air-to trial was only for 1 year, so they wanted to see what happened, long term, whether there was any structural changes in the airway because of the procedure. So the patients who underwent BT in the air-to trial were followed up annually for 5 years to assess the safety and durability of treatment effect. And they look at all these all aspects such as severe exacerbations, spirometry, high resolution CT scan. However, the air-to extension study was again criticized because there was no follow-up for the sham subject. And if you look at the retention rate in the air-to extension, it was very good because more than 90% of patients managed to complete their 5-year follow-up. And if you look at the result, no matter in what way you look at it, there was reduction in severe exacerbation as well as emergency room visit, which was maintained out to 5 years, meaning that the effect of BT can last for at least for 5 years. So what else is new about bronchial tumorplasty? Well, there was this study published in 2015 showing that regardless of the percentage of airway smooth muscle at baseline, you will get the same amount of reduction in airway smooth muscle after bronchial tumorplasty. And then there was a similar study in 2016 showing the same finding. Basically, it shows that before BT, there was a lot of airway smooth muscle, and 3 weeks and even up to 27 months post bronchial tumorplasty, there was a reduction in airway smooth muscle. And not only that, there was also a thickening, a reduction in the basement membrane thickness following bronchial tumorplasty. What about real life studies? So all these studies in various countries are basically case reports and perhaps case series, but they all shared one thing in common. All these real life studies showed improvement in AQLQ and severe asthma exacerbation. And then I think studies in Australia showed that the number of activation has a role in responsiveness, meaning that the higher the number of activation, the better the response. But however, there was a higher percentage of emergency readmission after the procedure as compared to the finding in the air-to trial, which was only 6%. Perhaps because in all these real life studies, they were treating more severe asthmatics. What about 10-year follow-up? They look at data from patients who were in the AIR-RISA air-to trial, even included those in the sham subject. So basically, they managed to show that the BT effects are sustained for at least 10 years in terms of severe exacerbation, hospitalization, and emergency room visit. And the findings from the global registry has been reassuring as well in countries such as Spain, Italy, Germany, UK, the Netherlands, Czech Republic, South Africa, and Australia. So 1 year and 2 years post BT, there is reduction in terms of severe exacerbation, ER visit, and hospitalization. What about the Malaysian experience? Well, we have been doing bronchial tumorplasty over the last 10 years, and we have presented our data 2 years ago at Chest World Congress, and we managed to show that we could our patient achieve good response in spite of us delivering lower activation. And our data has been accepted for publication in the Singapore Medical Journal. So the last few slides. So who is then a good candidate for bronchial thermoplasty? Well, to summarize, CHES and GINA guidelines, basically they support BT as an option for patients with severe asthma, with a caveat in the GINA guideline that patients with FEV1 of less than 60% were excluded in the pivotal trial, which was the AIR2 trial. And then ATS, ERS also support BP in adult with severe asthma, but only in the context of an institutional review board approved independent systematic registry or a clinical study. And what about the Malaysian guideline? Well, we think that BT is a treatment option in severe persistent asthma, and the use of this modality is to be decided by pulmonologists. And I think the ideal patient will be someone who is a frequent exacerbator despite maximal bronchodilator and ICS, and not a candidate or non-responsive to biologic, meaning this the type 2 low severe asthma. So back to our patient. So I'm pleased to share with you that the patient we offered bronchial thermoplasty and she completed it. She managed to complete the 3 sessions in 8 years ago, and then after 3 or 4 months later, her symptom improved. We managed to tail down her medication, and she's no longer on oral prednisolone. And she got pregnant, and her asthma was well controlled during her pregnancy. She only had 1 attack in the first trimester, and she successfully gave birth to twins. So it was a happy ending, and she's still well 8 years post bronchial thermoplasty. So my last slide, final food for thought. I hope I have managed to convince you that BT is associated with improvement in AQLQ, exacerbation rates, and ER visit. BT is an alternative therapy for patients with severe asthma that is inadequately controlled with medical therapy. There is histological evidence that BT reduces smooth muscle mass, and real-life studies and registries continue to support results from initial trial. BT appears to be safe with sustained effects for at least 10 years, but with risk of post-procedure exacerbations. With that, thank you very much. And I would like to invite all the participants at this virtual symposium to attend the 9th Asian Pacific Congress on Bronchology and Interventional Pulmonology, taking place in Malaysia virtually in October this year. And you'll be hearing a lot more about bronchial thermoplasty in October then. So we look forward to seeing you then in October. Thank you very much.
Thank you, Dr. Azizi, for your enlightening lecture. Thank you to all the keynote lecture speakers. Now we are entering the Q&A sessions. We are sorry to inform all participants that we only just choose 1 question per every speaker. The first question to Professor Jayes Danani from Dr. Julian Huningkor. How effective the treatment of aerosol therapy in cystic fibrosis, where all surface of pulmonary organ were covered in mucus, is still feasible?
Cystic fibrosis? Yeah, definitely. The effective therapy of aerosol therapy with cystic fibrosis, if you see the origin or the history of aerosol therapy in clinical medicine, cystic fibrosis patients have been at the forefront as the patient population that has been most studied with aerosol therapy. The combination of RH-TNAs, which is the recombinant HTNA therapy, is one of the interventions that have been used break down the sputum that covers the alveoli and the airway epithelium. And certainly, when it comes to infection in these patients, inhaled antibiotics in the form of immunocompromisant has got a proven role with really high quality clinical trials and evidence to support their use.
Thank you, for the explanation, Professor Jayes. I hope it will answer the question from Dr. Julian Hulinkor. And the second question is to Dr. Jamalul Azizi from Dr. Sumardi, spesialis penyakit dalam konsultan pulmonologi. After the thermoplasty make local inflammation in bronchus, could it will be developed into fibrosis? If it can, for how long, doctor?
Thank you. There's no evidence that BT will cause a structural damage to the airway. Patients have were seen for up to 10 years. No, absolutely no evidence that patient will develop fibrosis in the long term as a result of bronchothermoplasty. And there is a question, what are the side effects and contraindication of BT? Can I answer that question?
Yes, thank you very much, Dr. Azizi. There is one question to Professor Jayes from Dr. Gurmeet Singh. Any opinion about inhalation with saline 3% and 7% in non-BE patients?
A good question again. It's a 3% saline we've used very often in clinical scenario, largely because one, it is cheap, and two, it seems to be effective in patients with a high amount of thick sputum. So it ends up being used as a mucokinetic agent, where it actually adds to the water content of the mucus and enables effective clearance of thick sputum in different patient groups, mechanically ventilated as well as non-mechanically ventilated. The 7% saline, I would be a little bit concerned using a hyperosmotic agent of that quantity, 7%, largely because the risk of causing bronchospasm is quite significant, with very little to gain on top of its use with 3% saline, actually. So 3% saline certainly can be used. Just bear in mind that even in 3% saline, sometimes bronchospasm can be created as well. So in patients who can tolerate 3% saline, that is the cheapest way of actually promoting mucus clearance. But in the absence of if there is bronchospasm, then there are other agents such as Dornase alpha and bromhexin that you could use like a mucokinetic, a mucolytic agent.
There are a few questions. Recording in progress. Explanation, Professor Jayes. There is another question from the Q&A session. Will BD end the asthma problem in a patient of regular medication continue? To Dr. Jamalul Azizi.
Will bronchitis and the asthma problem on regular medication? Oh yeah, I understood the question. So bronchothermoplasty or BT doesn't cure asthma. Okay? It will only make the asthma better, actually, in terms of the control. So patients will still need to be on regular medication even after bronchothermoplasty. But what we can do is perhaps after BT, the asthma is easier to control, and we can reduce the number of medications after BT, and perhaps even if the patient develop an asthma attack, it won't be as severe as before BT. So it won't end asthma, but it makes the asthma easier to control, just like the case that I shared with you. Yeah.
For the explanation, Dr. Jamal Azizi. Because the shortness of the time, we'll end the Q&A session. And thank you for all the keynote lecture speakers, for all the enlightening lecture and amazing lecture. And don't forget to all the participants to join and participate in the NIND Asian Pacific Congress on Bronchology and Interventional Pulmonology in 8 to 10 October 2021. For more information, please visit www.apcb2021.com.